Hi, can you guys hear me?
Yes, we can.
Okay, and is this like the main room or the presenter view room?
It is the main room, but presenter mode is like how when you press it on the screenshot. I'm not sure on the power.
Okay, so yeah, but usually when the meetings occur, is it the same? Or who normally would lead the meeting? That's the point, because I've followed the link that I was given, so not sure if I'm on the right link though.
Hi,
Hmm.
are you here?
What's the question? Yep. I think this is the right link, correct?
Oh, okay, good.
Um, People usually just kind of get on like right at the time.
Okay.
Hey, Michael.
Hi.
Hi, how are you?
Good.
Thanks for joining us.
You're welcome.
And then can you remind me, just to make Omonigo, is that the right way to pronounce it?
That's
Yes.
fine.
But is it fine, but not correct?
I mean, it's pretty much great.
Oh, okay.
I don't expect you to speak my language, but
Wow.
that's excellent though.
We'll just give it a moment as people file in. Are you able to screen share? Are you just, okay, perfect. Okay, I'll
Yeah.
just go ahead and introduce you first. Just have a few more people popping in. Okay, well, we'll go ahead and get started. Welcome to our Grand Rounds today, everybody. I'm delighted to introduce Dr. Omonigo Bubu, who is an associate professor and physician scientist at NYU Grossman School of Medicine in the departments of psychiatry, population health, and neurology, with a programmatic research focus on sleep, aging, and Alzheimer's disease. Dr. Bubu is also director of the Aging Research in Sleep Equity and Dementia Prevention Program, Associate Clinical Core Leader in the NYU Alzheimer's Disease Research Center, and a core investigator in the NYU Institute of Excellence in Health Equity. Dr. Bubu has graduate, internship, and fellowship level clinical and research training in neurology, neuroepidemiology, and public health. His research examines how age-related and age-dependent sleep changes and vascular risk impact cognitive decline and Alzheimer's disease risk, and how they drive AD-related disparities. He has received various foundational and NIH grants to fund his research and has continued to establish his emerging national presence as a sleep and AD investigator. Dr. Bubu has been involved in various research projects that have established that sleep is associated with cognitive decline and AD. He has collaborated with experts in the field on intramural, foundational, and NIH grants with significant contributions that have led to findings with that serve as a critical step in the continuum of research expected to consolidate our understanding of how changes in rest activity patterns and sleep-wake cycles can be utilized as predictive and preventative tools to identify and treat individuals with Alzheimer's disease. We are thrilled to have you here today and are excited to learn from you. So I will turn it over to you, Dr. Booboo. Welcome.
Thank you so much for that introduction. I'll go ahead and share my screen. Okay. Yeah, so today I'll be talking to you guys about the impact of obstructive sleep apnea on neurodegenerative and Alzheimer's disease pathogenesis, examining physiologic, race, and sex-specific mechanisms. So these are my disclosures. They're just basically grant funding. And typically, I like putting learning objectives. The hope is that we'll be able to describe race and sex-specific physiologic mechanisms by which obstructive sleep apnea increases AD risk, and that we'll be able to describe interactive effects of objectively measured obstructive sleep apnea, Alzheimer's disease pathology, prospective cognitive decline, and Alzheimer's disease stage progression, and then be able to characterize brain Alzheimer's disease pathology patterns in cognitively normal patients with obstructive sleep apnea, as well as characterize cognitively normal older adults with obstructive sleep apnea at heightened risk of developing Alzheimer's disease. So generally, I'm just going to provide an update on putative mechanisms that underlie the association between obstructive sleep apnea and risk of developing Alzheimer's disease. I'll do that from a mechanistic, primarily preclinical perspective, as well as a clinical epidemiological perspective. So this is the outline. So I'll describe first the health equity framework that I use for current studies. I'll talk about obstructive sleep apnea physiology, epidemiology briefly, and then go into details with respect to data concerning obstructive sleep apnea as a risk factor, physiologic marker, modifier, as well as the associations with novel plasma Alzheimer's disease markers. Okay, so the focus of the research is not really going to look at this framework, but I thought to share the framework that I use to really, what I say it's an health equity theoretical framework to test an integrative conceptual model of race that's treated as a social construct, sleep and Alzheimer's disease. This framework applied to basically all the funding that we have. I'll just show you one. So typically, the focus is on a health disparity population and fundamental characteristics of that population. So in this particular case, the population are cognitively normal, older Black African Americans, ages 55 to 85 years. And so it's a hybrid model that looks at the medical model that examines downstream factors with the investigative focus on the individual domain of influence. So we're looking at mechanisms. So we'll look at obstructive sleep apnea and how that is associated with Alzheimer's disease pathology that we'll measure in the brain. And then we'll look at possible mechanistic pathways, in this case, looking at slow wave activity, and then inflammatory pathways as mediators of the association between obstructive sleep apnea and Alzheimer's disease pathology. But we're doing this again using the framework that I say is a health equity framework. So we're doing this within and between race. So, and treating race as a social construct as such, we move on to a socio-ecological model to characterize mediators that are proxies for mild to upstream factors. The investigative focus, again, is on the downstream mechanistic effects, basically the results that we've seen. And usually it's disparate findings, between OSA, AD pathology, in whites or Blacks, with one particular group having a higher burden. And so we look at all these mediators that are proxies for mid to upstream factors, stress, that will characterize via allostatic load, or we'll look at perceived stress discrimination, social environmental determinants of health, and then we'll also look at biological characterizations where we look at small vessel disease, white matter hyperintensities, cardiovascular risk, again, based on the literature, because we know that minoritized populations have a higher vascular burden. So typically this is just a framework, and then we'll look at this broken arrows, just indicative of the disparate outcomes that we can see, and that the mediators possibly explain some of the reasons why we see those disparities. Okay, so I'll move on to these. I'm not going to waste time here because I know this is a group that understands the physiology. Just briefly, with obstructive sleep apnea, the obstruction, as we know, either partial or complete. And then there are compensatory effects that occur with increased breathing effort that results in decreased PO2, increased PCO2, there's arousal. And all of this, like I said, not going to waste time on it because I'm sure that everyone knows this. And, the cyclical pattern of this continues to occur and can cause all the associations that we know, either with cardiovascular outcomes, inflammation, or cardiometabolic. And in these cases, we're trying to look at cognitive outcomes. So just general obstructive sleep apnea physiology. Again, I know this group knows this very well. The prevalence, as we know, depending on how OSA is characterized in the adult population, ranges from 9 to 38%. It could be as broad as 20 to 84, again, depending on how it is defined. We know that with respect to Alzheimer's disease, obstructive sleep apnea is 5 times more common in Alzheimer's disease than healthy control. There are anecdotal evidence showing that treatment of obstructive sleep apnea improves cognitive functioning in AD. And we know, and I know this group is very familiar with this, the consequences of obstructive sleep apnea on all the systems that we can think of: cardiovascular system, neurological system, reproductive health, kidney function, and all the others. Okay, so now I just want to present some evidence looking at obstructive sleep apnea as a risk factor for Alzheimer's disease. So generally, the premise is we've got these seminal studies that have been done looking at longitudinal association with obstructive sleep apnea and risk of dementia. Some of them were just 5 years, some extended to up to 15 years. But again, there are challenges with respect to either objective or subjective characterization of sleep disordered breathing or obstructive sleep apnea. Some had positive findings, the others negative, or some null associations. So whether obstructive sleep apnea precedes Alzheimer's disease onset remains an issue of debate. And as there are conflicting results, also studies that have investigated a prospective association between OSA and AD are limited. So what we tried to do here was basically utilize electronic health records to do a survival analysis in which we compared individuals with obstructive sleep apnea with non-obstructive sleep apnea patients. So the questions were, does objectively measured OSA precede the onset of AD diagnosis? And if so, what are the potential mechanisms of this association? And the other thing was, are there race and sex-specific biologic mechanisms of the relationship between obstructive sleep apnea and incident Alzheimer's disease? Retrospective cohort study, we used an extensive reach and source of sleep study data, looking at individuals with no history of cognitive decline or dementia. They were followed up for up to 13 years. Now, these are the Kaplan-Meier curves, the red indicative of obstructive sleep apnea, the blue indicative of no obstructive sleep apnea. And what we do see in, so we had two cohorts, a cohort, because this was basically electronic health record and sleep secondary data analysis. So some of our population, so we had two cohorts. The unexposed cohort 1 underwent sleep study, were not diagnosed with obstructive sleep apnea. The unexposed cohort 2 did not. So we selected that from the general population. But you can see that the representation or the graph, the survival analysis estimates and curves are pretty similar in both unexposed cohorts. What we see is that obstructive sleep apnea patients had an earlier onset of Alzheimer's disease diagnosis over time. And the Cox proportional hazard model and regression model showed that, and it does show what we will call a dose-response relationship, meaning with increasing OSA severity, you had stronger effects with respect to OSA and increased incident Alzheimer's disease risk. We also see sex differences in the risk with stronger effects among females. We also see racial ethnicity differences with stronger effects among minoritized populations. We also see educational level dependent effects. Again, these are not new with respect to education and even with respect of the racial differences, but this is new in terms of looking at it in the context of obstructive sleep apnea and incident Alzheimer's disease. And so the next thing was to look at the possible mechanisms that drive these associations. And what you see, we looked at hypoxia, disordered breathing measures, fragmentation measures, duration measures, and you do see associations across these measures. So in summary, for the first question that we really had a set of questions, we conclude that obstructive sleep apnea can possibly precede AD onset. We do see a dose-response relationship in incident AD risk as OSA severity increases. And some of the mechanisms were hypoxia, fragmentation, and duration measures as potential mechanisms by which OSA increases AD risk. And we saw that among patients with obstructive sleep apnea, race and sex-dependent effects relating to AD risk possibly exist. And so we wanted to delve more into this race and sex-specific mechanisms. And the premise really is we know that there are race-specific data on Alzheimer's disease risk. We know that Blacks are twice Black Americans relative to white as a 2-to-1 ratio. We know that with respect to obstructive sleep apnea, there's also racial differences. We know as well with respect to sex-specific estimated life risk for Alzheimer's disease. Again, it's different across racial groups with women having a higher burden. We know that there's sex-specific evidence of OSA risk, suggesting that OSA is more common in men. We do see that women compared to men, independent of age, weight, and influence of medications such as antidepressants, have lower AHI, less severe OSA in NREM sleep, more partial obstruction, and shorter events, more respiratory effort-related arousal. We know that women have a higher prevalence of REM-related sleep apnea events. And so the question here was, knowing these, are there race and sex-specific biologic mechanisms of the relationship between obstructive sleep apnea and incident AD? So this is looking at the various mechanisms, hypoxia, disordered breathing measures. The gray is representative of Hispanic. This is relatively brown, representative of Black African Americans, and the blue non-Hispanic whites. And here you're looking at within group risk with hypoxia, disordered breathing measures, characterizing tertiles. So you're having the highest tertile versus the lowest, or the middle tertile versus the lower tertile. But what we do really see is stronger effects, again, with minoritized populations. And when we compare these risk estimates, they're significantly different from one another. When we look at hypoxia, disordered breathing measures with respect to males and females, the blue representing males, females represent yellow. We do see differences, stronger effects among males relative to females. When we look at sleep fragmentation measures, we do not necessarily see any racial differences in those specific risks. When we look at fragmentation measures with males and females, we do see a reversal, now stronger effects in females relative to males. And then when we look at duration and continuity measures, we do see very similar stuff that we saw with hypoxia disorder breathing measures, with stronger effects in minoritized groups, Blacks and Hispanic relative to whites. And then when we look at sleep duration and continuity measures for male and female, we do not see sex differences. So what's the summary of that? So relative to whites, Blacks and Hispanics were significantly more likely to have increased risk for incident AD. We saw that in measures of hypoxia and sleep duration. We see that relative to males, females were significantly more likely to have increased risk of incident AD in measures of sleep fragmentation. We see that males were significantly more likely to have increased risk for incident AD in measures of hypoxia. And that sleep fragmentation and duration measure effects on AD risk were similar for races and sexes, respectively. So we say that possibly, right, mechanisms related to hypoxia, fragmentation, and duration measures might underlie AD rates and sex-related disparities. So the next thing was, okay, if obstructive sleep apnea possibly precedes the onset of AD, could we look at obstructive sleep apnea as a physiologic marker of AD pathology? Is it associated with Alzheimer's disease pathology? So this was a longitudinal study, sleep aging and risk for Alzheimer's disease, conducted by one of my mentors. Really, and I can give the description of the study here. I do have it here. So the question was to test the hypothesis that there's an association between the severity of obstructive sleep apnea, longitudinal increase in amyloid burden in cognitively normal elderlies, 2 years prospective longitudinal study. And this was a sample of community dwelling healthy cognitively normal elderly, 208 participants. Okay, no, I was a little bit. Is anybody saying something? All right, good. So subjects were imaged, and then we also had CSF measures of AD pathology, and monitoring of OSA was completed using a home sleep recording device. So what did we see? What we're looking here at here is the relationship between longitudinal change in CSF A-beta 42 and natural log of AHI at baseline. So we're looking at AHI-4 here, and this is the change in CSF A-beta on the x-axis. Now, with CSF, in the CSF, lower levels of A-beta is indicative of worse AD pathology. So what you're seeing here is with increasing OSA severity, the changes in the CSF A-beta levels is actually going towards the worst direction. This is using AHI-all, which is 3% with arousals. We're seeing similar effects as well. And then at cross-section, we looked at with PEEP, that's in imaging. And now in imaging, the levels of A-beta are seen where imaging, the higher, the worse pathology. And so here we do see that at cross-section, the severity of OSA is associated with greater brain A-beta deposition in amyloid positive individuals. And then when we look at the longitudinal change, we do see associations again with AHI-all or 3% DSAT and including arousals. So having done that, we wanted to expand the analysis of this longitudinal examination from purely cognitively normal older individuals to those across the spectrum of dementias with normal cognition, MCI, and AD. And then look at the effect of OSA on tau and its hyperphosphorylation. And basically to consolidate and bolster the observation in our prior work. And the main outcomes here were the annual rate of change in brain amyloid burden, as well as tau protein aggregation in the CSF. So what you see here is cognitively normal OSA subjects. These are the red indicative of obstructive sleep apnea. This is florbetapet that measures, helps to the tracer that we use to measure amyloid burden. And what you're seeing is that obstructive sleep apnea positive subjects had a faster rate of longitudinal increases in florbetapet PET uptake. We see that in the MCI group as well. And then when we look at CSF beta, we're seeing similar findings again. Lower levels of beta is indicative of Wall's pathology in the CSF. We see that as well in the MCI individuals. We do not see that association in AD, suggesting that there might be a threshold limit with respect to AD or a ceiling effect with respect to OSA's effect on AD pathology. But now we'll move on to phosphorylated tau. We do see now in the CSF with p-tau, that's phosphorylated tau, the higher levels are indicative of Wall's pathology. And then again, we see that increased faster rate of longitudinal increases in CSF p-tau in cognitively normal individuals. We see that as well in MCI individuals over time. This other study that I thought was very interesting to share was conducted, I think, in a secondary analysis of a randomized clinical trial in community dwelling older adults in France. It was cross-sectional, and the participants, again, community dwelling, very similar to how we select our patients. They were cognitively unimpaired based on standardized cognitive tests. They had PSG, MRI, and imaging, PET imaging as well. So what we're looking at here is neuroimaging patterns of significant differences between participants with and without sleep disordered breathing in amyloid deposition up here and gray matter volume. And you can see that in sleep disordered breathing individuals, they had a higher burden of amyloid deposition, higher gray matter volume. These are cognitively normal individuals, as well as higher perfusion and higher glucose metabolism. So the hypothesis here is, possibly again, in cognitively normal individuals, we're probably having inflammation with extravasation of fluids that would possibly cause gray matter volume increases. Then over time, before you now begin to have neuronal atrophy or changes that now results in the loss of neuronal substance in the brain. So when you look at the overlap, you can associated overlap of SDB, associated brain changes across the neuroimaging modalities. What the conclusion is we're seeing greater amyloid burden, gray matter volume, perfusion, and metabolism. But the key finding here is they're overlapping in AD signature regions, which are like the posterior cingulate cortex, the precuneus, usually in the medial temporal lobe. All right, so what's the summary? We see that OSA severity is associated with longitudinal increases in amyloid burden in cognitively normal elderly. We're seeing that both cognitively normal and MCI subjects will also have an increased annual rate of change in brain amyloid burden and tau protein aggregation. And that cognitively normal subject will also show greater amyloid burden, gray matter volume, perfusion, and metabolism that overlaps in AD signature regions. So having looked at the fact that, okay, OSA possibly precedes AD risk, we're seeing that there's an association with the pathogenesis itself, with biological markers. Is it possible, especially based on what we saw when we had to stratify by amyloid positivity and saw that the effect was more in the amyloid positive individuals, is obstructive sleep apnea, can it possibly act as a modifier of AD risk? So here, the objective was to look at, does OSA have a direct neurotoxic or neurodegenerative effect? And is this effect independent of a beta or tau? This is AD pathology that is sufficient to induce prospective clinical diagnosis of cognitive decline, or whether there's a synergistic effect, that significantly increases MCI AD progression risk. So these were participants from the ADNI cohort. We grouped them by the AD biomarker profile, where A is indicative of aggregated A beta, T aggregated tau, and neurodegeneration. And this is how they're classified. So I go to the results. So here, we're looking at Kaplan-Meier product limit survival estimates, and I just want to bring your attention to this group. So this group have amyloid burden. They're A beta positive. Okay, now A beta is AD pathognomonic. It is very pathognomonic for Alzheimer's disease. The levels across a particular threshold is indicative that the individual has evidence of AD pathologic change. So that's a big risk factor. And then these individuals have ORSA and evidence of amyloid pathology. So what do you see here? You see that the presence of obstructive sleep apnea, right, really increases that risk, you know, in terms of progression from normal to MCI. And we look at this in MCI, this will be progression to AD. We see a similar pattern. These guys have their A beta positive only, and these guys have ORSA plus A beta positivity. So we're seeing the additional effect of obstructive sleep apnea in the presence of A beta positivity or evidence of amyloid pathology. We look at this with the presence of tau. So these individuals are ORSA positive and tau neurodegeneration positive. And we look at these individuals as tau and neurodegeneration positive. So again, we see a significant progression, time to progression from normal to MCI in the ORSA and tau positivity group. We see that similar with respect to MCI to AD progression. These guys are TN positive, and these guys are ORSA and ATN positive. All right. And to you know, look at this in terms of the interactions, we did logistic mixed effects model estimates, and you can see that there is a synergistic effect with ORSA and A beta from normal to MCI, and A beta with tau, as well as MCI to AD, A beta with tau as well. All right. So again, so basically we're saying that somehow ORSA possibly has a modifying effect. So wanted to look at it, knowing that vascular risk factors act synergistically with A beta burden to promote cognitive decline. We also know that A beta burden and neuroimaging evidence of cerebrovascular pathology on cognition show additive effects, and that a substantial number of ORSA patients have co-occurring vascular risk factors, including hypertension. We know that hypertension is an established risk factor for AD, Alzheimer's disease. So we wanted to look at, does ORSA modify the effect if people have co-occurring comorbidities? So this was basically the analytical plan where we had ORSA direct effect on longitudinal changes in AD pathology. We looked at the hypertension effects. You can see that the hypertension effects are stronger. These are standardized estimates. We'll look at the synergistic or the effects, the combined effect of ORSA hypertension, and you can see that it's on the multiplicative scale, showing a synergistic effect. We'll look at the direct effect of ORSA on longitudinal changes in cognition. Now looking at clinical symptomatology, we'll look at the direct effect of hypertension. Of course, it's stronger. And then we'll look at the combined effect. We see, again, on the multiplicative scale, a synergistic effect. All right. And to visualize this is what we're really looking at. I bring your attention to this group that have ORSA positivity and hypertension positivity, and you can see that the trajectory is steeper than every other group. All right. Now, using the ADNI data, ORSA, because it's kind of a little bit subjective, but you know, people were asked if they've been diagnosed with ORSA. So they said yes. But this is now using our own data where we used objective measures. All right. So it's a pretty similar design where we're looking at the interactive effects of objectively measured ORSA, beta, and tau on clinical prospective cognitive decline, and then on AD stage progression. So again, similar finding that we were able to replicate. Bring your attention to this group. This is the ORSA positive, A beta positive group. And then we see a steeper decline. This is with respect to prospective cognitive decline. The logistic mixed effect models, where we look at the comparison between the groups that have ORSA positivity, A beta positivity, with the ones that do not have, you can see clearly we're seeing very clear effects of the additive effect of obstructive sleep apnea positivity in the presence of Alzheimer's disease pathology. So what's the summary? Our findings really support the hypothesis of an overarching model of late onset Alzheimer's disease with brain amyloid deposition and tau aggregates that proceed at different rates. And it implies a contributory role of obstructive sleep apnea, first with a direct potential for neuronal injury that's independent of AD pathology. But then we see an indirect contributory role that may accelerate A-beta and tau accumulation in the presence of A-beta plaques. Again, possibly by a feedback loop. This role we see significantly increases MCI-AD progression risk. We see OSA beta synergism. We see OSA beta and tau synergism as well. So, and then we see that the co-occurrence of OSA and hypertension interacts synergistically to promote amyloid burden and global cognitive decline. So having looked at that, we know now in the AD field, right, there's novel plasma markers. And so if we've seen this with established markers, which are CSF and imaging, can we see this in these novel plasma markers really? This is just letting you know, if you look at the CSF biomarker models and the plasma marker models, I just want you to look at the dynamic ranges, and you can see they're pretty similar. Overall, though, plasma markers have smaller dynamic ranges, except for CSF and plasma p-tau, which are similar. So we just wanted to look at whether there was associations with plasma AD biomarkers. And so what we do look at with the beta markers, you do see some level of correlations, significant correlations. And then with respect to tau, tau represents non-specific marker for neuronal injury. Again, these are cognitively normal individuals. We do not see a significant association, but having known that there's a possible interactive effect with a beta pathology, what we now did was look at an interactive model with a GLM estimate. And if you look here, we do see that, you know, there is an interactive effect when we make the association dependent on the presence of amyloid burden. So in the presence of amyloid burden, OSA interacts synergistically, and you see effect on plasma tau and NFL. All right, and then, you know, the thought really is, the goal is for large clinical trials in the community. And to be able to do this, we think we need to do large trials. We'll need to be able to not do invasive procedures like we do, you know, CSF, lumbar puncture, imaging, PET tracers that will be injected. Can we take blood, you know, only, right? But we're focused on a sleep group, obstructive sleep apnea, and we want to do a trial. Can we, you know, determine the risk in these individuals just by taking blood and looking at their OSA severity? Basically, that's what this is about. And so what we do see when we do an ROC curve, and I just put your attention on the left, we're looking at brain amyloidosis. The model 4, right, is the model that has plasma beta 42/40 ratio, which is a known marker. It correlates very well with the established markers of AD pathology. When we look at that plus AHI, we see that the AUC is about 78. And then model 1 is just a beta 42/40 ratio. But you just look at with the presence of AHI in OSA patients, you're seeing that this significantly improves brain amyloidosis, you know, detection. We see that same pattern in tau with model 4, a beta 42/40 ratio plus AHI. And then we see that. The model 1 is just a beta 42/40 ratio. Model 2 is adding all of the markers that we know, all of the variables that we know are established markers. But we see that the model that does the best is the model, again, this is a sleep population with AHI4. Just testing to see, again, this is just preliminary, to look at, okay, if we're going to do trials, we'll need to treat. Can we mimic or do an experimental design where we do an acute withdrawal, and if we see acute effects or changes in these plasma AD biomarkers. And so this is what we did. So we analyzed blood collected in the evening and next morning, 30 individual severe OSA. Participants were about 52 years of age, 27% women, 67% non-Hispanic white. And what we saw was acute OSA induction resulted in an evening to morning increase in plasma NFL, and you have a decrease in plasma beta 40. So with the ratios, a lower levels of plasma beta 40, 42 ratio is indicative of worse pathology. These guys are more or less, again, in the cognitively normal early MCI spectrum. So we're just looking at the acute effects of PAP withdrawal, not necessarily knowing what the long-term effect would be. So, but this is what we're seeing accurately. All right, so the summary is we see OSA severity associated with levels of plasma amyloidosis. We see a synergistic effect with CSF-beta on the neuronal injury markers. We see that the combination of plasma beta 42/40 and OSA severity improve correspondence with CSF amyloid status and CSF p-tau status. And we do think that OSA may be contributing to overnight neural injury, potentially via fragmentation and/or hypoxic burden. And these are the proposed mechanisms that we're working with, intermittent hypoxia, fragmentation, duration measures, and then, also looking at the intrathoracic pressure swing CSF-ISF exchange. That's the glymphatic system and how sleep impacts that as well. We're looking at vascular pathology. Some of this we've already investigated, and others were in the part of the things that we're investigating are all in here. Again, we're doing it in the context, like I said, of a health equity framework. All right, so in conclusion, I see that we see that obstructive sleep apnea increases AD risk by up to 2.4-fold. We're seeing that mechanisms related to hypoxia, fragmentation, and duration measures may underlie AD risk and sex-related disparities. We're seeing that obstructive sleep apnea is related to changes in markers of AD pathology. We're seeing that the co-occurrence of OSA and vascular risk may serve as a marker of progression risk, complement other AD biomarkers. We're seeing that in cognitively normal MCI patients, obstructive sleep apnea modifies the risk of progression. And then furthermore, OSA positive subjects may be more physiologically susceptible to AB load at certain threshold levels. Again, when we looked at these associations that I've described, in AD dementia patients, they are not there. So, and then we do see that if we want to do big trials, the possible, just taking plasma, looking at a beta 42/40 ratio, and the addition of OSA severity, they may represent a minimally invasive, reliable, cost-effective blood test that can potentially power large clinical OSA AD trials. So these are my acknowledgements, and these are people I work with. Many are my mentors. This is acknowledging everybody, and thank you.
Great. Thank you so much for that. There are a number of questions that have come up in the chat. See if anyone's, people are great. Thank you. Okay, the first question was from Ron Chervin. Were the patients with OSA treated over the 2 years?
All right, very good question. So we recruit from the community. So we're basically, they don't even know that they have OSA. So they're not treated. But of course, at follow-up, we do, once we have that diagnosis, we do ask them we suggest treatment and all of that. But we just have five to, if it's too much, 10% of the population that we serve, or the research participants that go for treatment.
Yeah, that's similar in other studies. Unfortunately, these research studies where a large number of people are informed that they have sleep apnea, a lot of them don't get treated. I guess it doesn't surprise.
Yeah, but with the second data, the ADNI data, again, we did and the paper is published, there was CPAP in the CPAP treated, who reported CPAP treated, we saw that these individuals, had, again, it's anecdotal, some relative delay in terms of progression. So again, anecdotal effect of CPAP.
Thank you. And then there's a question from Shelley Hirschner. Did any of these studies look at OSA plus sleepiness versus patients that had OSA but were not sleepy?
Very good question. So interestingly, again, like I said, we recruit from the community. Generally, our populations are not sleepy. So this is for the research so this is for the primary data collection. For the ADNI, this is secondary data. We don't have sleepiness data, so yes, that could possibly explain some of the findings. But what we're doing right now is characterizing, and I didn't show that data, specific OSA phenotypes, right? And looking at how they progress with respect to prospective cognitive decline, and how that might even impact AD pathology. And so we're working on that now. And looking at other novel metrics, hypoxic burden, ventilatory burden, arousal threshold, and the likes.
Thank you. Thank you very much. It's a great talk.
And there's another question from Punita Vijay Kumar. Are these patients ones who had OSA for several years? And if you could comment on their age too.
Yeah, okay, very good question. So one of the challenges, right, is we never know when the onset of OSA, really, because it's when you engage or you come in contact with, if it's patients or research participants, that you actually know. And so we can't tell how long they've had OSA, so that's a challenge, actually. So I'm not sure if, was the question is if we knew the duration of OSA for the patients?
Oh, Punita, you're muted.
The AD pathology kind of doubles every decade after 65, right? So when they are about 80 years, almost 30-40% have the AD pathology can be, still they being in normally cognitive or MCI levels. How do you account for somebody who is, I mean, they're older, 65, having OSA, compared to somebody with the 80-year-old with the OSA, their burden of A beta protein and tau?
Yeah. So you can see what we try to do, right? When we characterize them with our population with ATN status, and when we looked at within those strata, the progression, so we could actually delineate the independent effect of obstructive sleep apnea, right? With the presence of AD pathology. So you look at people with A beta positivity, alone, no obstructive sleep apnea. People with tau positivity or ATN positive, no obstructive sleep apnea. You look at their trajectory, and then you look at those with the presence of all of this pathology plus OSA, and you're seeing that OSA plus those are moving faster. So we think it's the independent effect of OSA that we're able to delineate, So in terms of the level, right, whether the particular threshold is now higher, we can't say for sure, because usually, there are many factors that what we call cognitive reserve or brain reserve that will tilt someone into symptomatic presentation. So someone can have an amyloid levels that will characterize as 1.2, and they are full-blown AD already. And some will have 1.1, and they are still relatively, so what we're looking at is the clinical progression. With respect to biomarker, what we do see is from cognitively normal to MCI, the rate of change is faster, right? But not necessarily whether the burden is now higher, because again, that doesn't really correspond or correlate with symptomatic onset. It's tau, p-tau that really correlates with symptomatic onset. And once they begin to have higher levels of tau, then, sometimes they begin to show, depending on their cognitive or brain reserve or their resilient factors, right, will begin to show symptoms.
Okay, thank you. And then there's a question from Xinghan too. Can you share evidence about OSA treatment and its effect on AD progression?
Yeah, so I say that those are very, and I use the word anecdotal, right? So it's looking at patients are more concerned about symptoms, right? Clinical symptoms. So there are anecdotal evidence showing that CPAP has effects on certain cognitive domains, right? Executive function, sometimes processing speed, right? So, but these are anecdotal, but there's no real strong evidence. We're just conducting those studies now to look at obstructive treatment with AD pathology, the markers themselves, right? So those are studies that are ongoing right now, and there are clinical trials, and one of them we're doing in which we're using a multimodal treatment paradigm, right? And to look at, but this is again plasma markers though. So that's we're not looking at in the established markers yet, but just looking at acute changes, and some data I showed you, looking at CPAP withdrawal effects or treatment effects, we do see acute changes, but what that means, we don't really know, because again, these are not AD patients. We know that from all of the trials that have targeted Alzheimer's disease or late stage dementia, they didn't work. So now everything is going towards early onset or the very earliest stages, right? But most of our population are, again, cognitively normal, MCI. What those acute effect means on the long term, we don't know. So we're conducting long-term studies where we can follow people for up to a year, up to 2 years, and see what that effect could be.
Thank you.
Thank you. And then Ron Shervin, you had more questions.
Yeah. I'm interested to know where you think the research is going, and will we ever get to proof of cause and effect ultimately through an RCT, which would be obviously very challenging to do, or where will we stop short of that and conclude that we should tell patients that there's cause and effect? Or what are you doing at your center with regards to all those considerations?
Yeah, again, I think what I've showed or described here is a starting point to look at, whether A comes before B, right? To look at whether there's an association with the pathogenesis itself, to look at whether there's a modification of the presence of that disease on progression risk. And so what we now need to do really is trials, right? And you noted, it's pretty tough to conduct these trials, but they're ongoing right now. I know of 2-3 funded trials, and I know trials that are under review now, specifically looking at interventions for obstructive sleep apnea and AD pathology markers and the clinical progression. So we'll see what those trials say. I do think that, AD, as much as we clearly define it in terms of its homogeneous definition of the presence of amyloid or tau, right, is really a heterogeneous disease with so many pathways that could contribute to the accumulation of these pathological markers. So for someone like, or for people like us, right, our focus is on the sleep population. And by that, I mean people who are suffering with sleep disorders, all that kind of stuff. So I think, and then the hypertension, people are focused on their hypertension because we know that that's already an established factor. So we need to show those trials are effective. show some relative effect before we can even convince Lancet Commission to include sleep as a risk factor, because they haven't yet. They put it as a novel potential risk factor, but it's not really established yet. So once we begin to do these trials and we see things coming out, and then we can put sleep in there. But the challenge also is sleep is so complex, right? We're looking at different. So what I showed you now is just obstructive sleep apnea. There's a whole stuff that just looks at sleep in terms of duration, short sleep duration, and look at the various aspects of sleep. We are looking at EEG characterizations and markers and what have you. And so we may be confusing the Lancet people as well. Like, okay, when we say sleep is a risk factor, which one is it, right? Because it's not hypertension, it's just, the levels of systolic versus diastolic, that's it. But with sleep, we're talking about various disorders. We're talking about just disturbed sleep as in question. So I don't know, but we're taking baby steps, and hopefully we can get there. I do think that duration, fragmentation, and hypoxia, and that's why I always say I think is very important, with respect to cognitive risk and Alzheimer's disease in particular.
In the meantime, do the clinicians at NYU show the sleep patients who are not using their CPAP every night those graphs about what happens to amyloid and tau after one night of not use, and does that motivate them?
Yeah, absolutely. At least that's what we're doing. But we're very careful as well, to note that this is what we're seeing in research, and it's not really, definitive in terms of clinical practice. But we're saying we talk about it in terms of prevention. Make sure you're using your PAP. Make sure you're sleeping right, because there's a potential. We don't, and this is what we're looking at. Absolutely, we do counsel and do that. We go into the community and do a lot of community engagement and educate people. But yeah. But we don't know if it's causal, though. We don't. We do know that there is a strong association.
There's one more question.
Afifa, did you want to unmute and ask your question?
Sure. Thank you. I thank you for a really great talk. This was very, very informative, and I really enjoyed it. I do apologize, I was a little bit late joining, but my question was the associations that you saw, I mean, I know you had mentioned near the end that it was with the AHI 4%. Was the association also there with the AHI 3%? The reason I ask is it more of a hypoxic burden thing that's contributing versus there's so many, as you were alluding to, there's so many other factors at play, right? Like, so when you have respiratory events, you have sympathetic surges. Is it the same role that the hypertension is doing? Is it a different pathway? So I was just wondering if there was an association between both or just the one.
Yeah, with both, yes. We saw with AHI 4% and AHI 3A. So we did see that. So it was with both. Like I said,
Okay.
what we're doing right now, following the field and trying to phenotype OSA and characterize them based on, whether sleepy or non-sleepy. We're also looking at endotypes and looking at and using novel metrics, right, to hypoxic burden, ventilatory burden, and arousal threshold. We, as I speak, we're conducting those analyses right now. Hopefully we'll get some good data to present at the sleep conference. So just to look at how the risk might differ across these phenotypes or using some of the endotype. Well,
Thank you.
Thank you. Any other questions for Dr. Bubu? I don't see any other hands up. Thank you so much for a fantastic talk. I think we all learned a lot. So thank you for sharing your time with us today. And we hope you come back again.
Yeah, thank you so much for the invitation. I appreciate this.
Of course. Take care. Thank you.